of this Congress. Continuing on the theme of THR, the topic given to me is intrapelvic fractures during THR, intrapelvic and intraoperative femoral fractures also. We'll cover both of them. And over my last 27th year is ending of my clinical practice. And there have been very crucial times when I was reaming once and the femur broke, and actually it spun the whole distal femur, although it was not a very old patient, young middle-aged lady in 50s, and the whole femur had a spiral fracture distal to the middle. And this was a primary case I was doing. I was shocked. So first time when it happens really puts you back. And then I've had about 2 at least acetabular fractures also during during impaction. And they happened during impaction. They were certainly old ladies, and I think both were revision cases when they were kind of bent bound or chair bound, so bone was quite weak. And then femur, we have on the femoral side cracked, I think maybe at least 10 times the calcar. And calcar, especially when you're doing a cementless and you are erring more on the side of primary fixation and choosing the biggest size that whatever you have, and suddenly you see a small crack in the calcar opening. That's the easiest and quickest, commonest example that anybody can allude to during a THR. And then a simple cerclage wire suffices, and you proceed with the same implant, and you don't have to change your plan except 10 more minutes for the cerclage wire. Anyhow, so those were personal experiences, but what does the book say about it? Let's go through in the next 10-15 minutes or so. So intra-periprosthetic fractures during hip replacement are significant and complex complication with reported incidence rates of 2.4% in primary. Mayo Clinic registry says that 1.7% to about 12% during revision procedures. Intraoperative acetabular fractures also happen, but are less common and less reported also because they are picked up less also. So as I said, there can be patient-related risk factors, which are osteoporosis, small size of the anatomical femur and the acetabulum, and we are trying to put in the smallest and reaming more. There can be pre-existing deformity, osteolysis or loosening in revision cases, prior surgical defects. This can be a post-traumatic case, as was shown by Dr. Kazim, and there can be excessive loads. Patient can be very bulky also. And then obviously, if we don't have proper implants and proper cement removal techniques, we would end up in breakage, right? So revision cases, both commonly it happens that you are removing cement in the canal or even in the cup, you end up with a chunk of bone attached to the cement despite all your care and despite all your instrumentation being present. Implant sizing, as I mentioned, as Dr. Shaidnur also mentioned, you have to have a complete armamentarium of implants in primary, and don't just better to cancel the case. And I would echo the same after so much years of experience. It's better to cancel the case and not be pushed by your vendor that we will handle. So they cannot handle, and it'll slap back on your face if you are using an undersized or an oversized implant. So implant variables, as I said, you have to have adequate poor complete circuit of implants, and then also these are not minor surgeries, they need backup, they need trauma system backup. As I will show you some example, if something goes wrong, you need an instant trauma system backup, a plate, a screw, or a trochanteric plate. So they have to be in your backup armamentarium. So first, femoral fractures, high index of suspicion, careful intraoperative inspection are fundamental to immediate diagnosis and treatment. Sudden change in resistance, pitch or position of component should alert you that there is a distal crack or there is a distal hole, and urge to not to treat minor cracks, just ignore them. You should not ignore them, otherwise they can propagate and lead to complete fracture and sometimes also open up the canal. When they occur, fractures should be carefully exposed, fully exposed to ensure their lower or distal level so that complete propagation is visible to you. So even if it is a calcar, you should expose the proximal femur ताकि आपको उसका extent पता लग सके. A lot of times we use the curette, long curette, to evaluate all the four walls, especially when junior people are engaged in surgery and surgical training. It is my job to ensure that they have not cracked or perforated a cortex, right, during their reaming or broaching, either of them. So long curette helps you to kind of locate any hole that may be present, and then of course you need a C-arm to confirm that. So patients at risk, females are at more risk, elderly patients are at more risk, and those with uncemented stems are at more risk. Stem fracture can occur early while attempting to dislocate hip. That's another problem in stiff arthritic hips, osteoarthritic hips. There may be big osteophytes resisting dislocation. So that case happens, you have to kind of make sure that you have completely opened up the capsule or removed the capsule, whichever approach you are going through, and then attempt a dislocation, a gentle dislocation, making sure you don't crack the femur or you don't create a spiral fracture in the femur. In that case, the best would be to do an osteotomy right there without dislocation and then remove the femoral head. So especially rheumatoids have very weak bones, they have been on steroids, you can easily create a torsional fracture. In patients with complex deformities of proximal femur, increased risk of fracture, especially when the medullary canal is narrowed, right? You are trying to ream, and then you can have a false passage and can perforate. Revision surgeries carry substantially higher risk of fracture than primary because of presence of thin cortices, implant migration osteolysis, and then the patient has been bed-bound or chair-bound. That adds to the osteopenia that exists secondary to the primary pathology. So they can, as I said, occur during broaching or insertion of the femoral component, either way. If resistance is met in attempting dislocation, more of the capsule should be released, osteophyte excised, and as I said, osteotomy done in situ rather than after dislocation. Then in cases of intrapelvic protrusion of acetabulum, neck should be divided, head removed beforehand. Broaches are designed to crush and remove cancellous bone and do not remove cortical and osteal bone safely from diaphysis. Need to remove cortical bone distally can be anticipated from pre-op templing, and that's where we would need reamers. Reamers are for cortical bone, broach is for cancellous bone, and straight or flexible reamer must be used to remove this bone before insertion of the broach, or a major fracture extending into the fracture femur shaft may occur. So best is to have, as I said, trauma armamentarium, and many a times when I am finding difficulty, I would put in a guide wire and call my flexible IM nail reamers and ream the canal, right? Sometimes it's impossible to even put the one size broach in, so I would ream with the femoral reamers. They are flexible. Size का mismatch जरूर हो जाता है. If you ream till 13, that may not be the implant size ultimately, so you have to kind of judge that out during surgery, but those are really helpful. So periprosthetic fractures have their own classification system: A, metaphyseal; B, diaphyseal; and C, distal to the edge of the stem. And then each is divided into simple perforation, which will be A, for example, A1 or B1, and the B1 would be diaphyseal perforation, B2 would be non-displaced fracture of the diaphysis, and B3 would be a displaced fracture of the diaphysis, and similarly C1, C2, C3 also. And these are quick fix solutions also for simple perforations, either cement or bone graft, And then most handy things are cerclage wires along with plates, and you decide intraop whether to use plates or simple cerclage wire would suffice or cables would suffice. But usually that's a decision taken by the surgeon on table. It's a totally undisplaced fracture. I may come out with multiple cerclage wires and my implant if it is stable enough. And there are ways to check your implant after this fixation. तो बंद रोक दें फिर हाँ ठीक है बिल्कुल that is more important. So I'm being told that we need to stop. So for the live surgery. Okay.
Extremely sorry for the interruption, sir, but our live surgery has been started. So we are moving toward.
Let's wrap it up. Back to the classification of intraoperative periprosthetic fractures. And we were saying simple techniques. We know the classification now. A, B, and C. A1 is perforation. 2 is when there is a non-displaced fracture, and 3 is when there is a displaced fracture. So it can be either for A or B or C. C is extremely distal to the tip of the implant. So that goes for B, and this is pictorial representation of the same. Again the same. Now coming to treatment, treatment options include cerclage wire, ORIF depending on level of displacement and fracture, bone grafting if required. If it is displaced and you think okay, there is still a gap, you cannot reduce it completely, you want to add bone graft there. And then obviously if the stem, you haven't stemmed it yet, a long stem option is always there. Femoral fracture instrumentless THA must be completely exposed to its most distal extent and even actually beyond. If you plan to plate it, you have to go at least 3 or 4 screws below it. This is done with broach or actual component in place because fracture gap may close when implant is removed and extent of fracture may be underestimated. Once fracture is exposed, implant is removed, cerclage wire or cables are placed around shaft, and if component is stable, patient may be allowed protected weight bearing. Trial broach one size smaller can be used to prevent over tightening and partial collapse, and then when you use the actual implant, you can because of it expanding, the tension of the cerclage wire is regained and the implant is a reasonable fit. More commonly, as I said, calcars, and then another common thing to happen is greater trochanteric fracture. And the method best used for them is trochanteric plate, and I will show you why. There is a tendency to underestimate such fractures and regard them as stable, which is a fallacy, and all greater trochanteric fractures should be treated seriously, must be fixed adequately, and believe me, over the years we have learned that simple screws would not suffice, tension band would not suffice, and trochanteric plate is the best option for their stabilization. So sometimes if you are considering in a rheumatoid patient is very weak and you are using a cementless implant, then prophylactic cerclage of the calcar can also be done, and we have done that. Coming to acetabular side, they are difficult to recognize actually. That's why underreported, and they are rare in themselves, less common than femoral side, but again, whenever they happen, they are underreported, especially when they are covered with the cup, and on an AP pelvis they may not be visible unless we do the obliques, the 2 obliques, or a CT scan. Published incidence about 0.09 to 0.4, and somehow the recent study shows incidence of 8.4% also. Again, the risk factors: insufficient acetabular reaming, imprecise reaming, application of cementless monoblock or elliptical acetabular components, and prior pelvic irradiation, female patients with poor bone quality, all are risk factors. Due to low numbers, there is lack of consensus regarding optimal treatment approach. Management requires high level of understanding of acetabular osteosynthesis and substantial level of proficiency in performance of revision arthroplasty. Thorough examination of acetabular rim and floor along with immediate intraop fluoroscopy is required for detection. So you need to be a good pelvic trauma surgeon also if you encounter that. Otherwise, call your colleague who does acetabular fracture fixations more frequently. He may be of good help. Stress testing can be done to kind of elucidate the proximal and distal extent of the fracture, and you would need intraoperatively all these three views. So इसको भी classify किया लोगों ने acetabular fractures, intraop, periprosthetic. Type 1 is intraop during component insertion, and ABC recognized stable, undisplaced, recognized displaced, cup is stable and not recognized intraoperatively. ABC is ready. And then during component removal, when you're doing a revision, a cemented implant or even an uncemented implant, once it is integrated, it's very difficult to remove. And if you are less than 50% bone stock, it will be 2A, and more than 50% bone stock, it will be 2B. Type 3 would be traumatic, component stable versus component unstable. Type 4 would be spontaneous, and type 5 will be total pelvic discontinuity when the pelvis drops into or breaks into two complete north and south poles with subsequent bone stock either 50% से ज़्यादा है या कम है. And then type 5C is the worst thing, which is post pelvic radiation, and it's a nightmare to heal that type of pelvis. So again, we have to take care of the fracture and patient dependent factors which may always be there. Now, how to salvage such a situation, and additional screws is the simplest step. So all a multi-hole cup is probably a best and simplest solution which you can use, and you can use your knowledge of anatomy to guide your screws into the ilium as well as in the ischium, so that you gain some hold through the cup and you don't have to do any extra dissection. Most of the fractures, undisplaced fractures, would heal. So loosening of the cup is indicator of early revision. In case of displaced fracture with unstable acetabular component, they need to be removed. Fracture geometry assessed, judo views done, pelvic discontinuity suspected, and here use of multi-hole cup may not be sufficient. You will have to plate them. So if you are doing hard hinge and supine, that will be very difficult because you cannot go to the posterior column or posterior wall. So hard hinge, as Dr. Shahid was doing in a lateral position, is very easy to convert that into a posterior approach and do a plate of the posterior column or posterior wall. However, anterior column can still not be reached by a hard hinge. You have to go either for a stopper or a linear inguinal. So in any case, if you are doing a hard hinge, a lateral position hard hinge may be more beneficial if you encounter such a situation, because you can immediately go to the posterior column. So osteosynthesis recon plate is the preferred surgical technique, and bone grafting may be required depending on the gap and the level of your screw fixation. Antegrade or retrograde column screws, जो पीछे last line है, may be required, and they be additional option. If you know how to put them, they are very valuable. Now, anti-protrusio cup cage construct can also be used as a last resort. So multi-hole cup, then osteosynthesis, and then the last resort is the cup cage construct, where you put in a cage and then you cement the cup. This goes without saying that you have to fix the fracture. So for example, in pelvic discontinuity, continuity of the pelvis must be restored to support stable cup anchorage with long-term osseointegration. Cup cage technique may be potential alternative to a combined hip procedure in such cases. Periprosthetic acetabular fractures with pelvic discontinuity, there is very little evidence regarding optimal treatment. Achievement of primary stability of acetabular component and long-term osseointegration is a challenge in bicolumn and T-shaped fractures. Three options are available, as I said: combination of osteosynthesis and total hip. In a combined hip procedure, endoprosthetic reconstruction using conventional anti-protrusio cage, and then lastly a cup cage construct. ठीक है, यही तीन ऑप्शन है हमारे पास फिलहाल, और तो कोई intraoperatively right there and then. So that goes to show the level of backup you need to have even for a primary hip, especially when those patient factors are active, and you can sometimes estimate a fracture. Example, so a type B which is slightly displaced, So it will be 2B2, and that has been adequately treated with, these are not my examples, these are from the internet, again by a plate on the lateral side and by cerclage wire, so well reduced and healed well. Another example, again fracture line is just type 2B at the tip of the implant. If you can see this, okay, at the bottom of the medial side of the implant there is a fracture, and that has been fixed again with cerclage wires only or cables, and that should suffice. Was a type 2A, very minimally displaced, as considered opposite to this one, which can happen while you are reducing or you are doing a trial implant and you are dislocating. This can happen especially in rheumatoid patients. You break right there and then, or patient can break post-operatively, and that would not be sufficient to do cable grafting here. You need a big plate, as has been shown, and actually double plating has been done here, an anterior plate as well as a side plate. So despite it being a cemented implants, you need to work your way out through the periphery of the cemented implant to put an anterior plate and as well as a big lateral plate. Now, fractures of the greater trochanter happen frequently, as Badr Saab, I think, was saying in the morning, that during anterior and lateral approaches during reduction, they fixed it with a smaller implant, continued to displace proximally, and ultimately it ended up in non-union straight proximally. And they will have a limp, but they are otherwise stable, otherwise implant is stable, so these patients can be left alone if they are sedentary and their demand is not big enough. Another example, greater trochanter, bigger chunk fracturing, they captured it with a plate and a cable, it went into non-union, and then they accepted that non-union greater trochanter displaced despite all fixation. Right, so this can happen, these are realities of life, again pictures from the internet. Another example, greater trochanteric inadequate fixation with a smaller trochanteric plate and single screw. So whenever you want to use it, use a longer plate effectively, and that should result in good healing. So it is plastic hip fixed with breakage of the quadrilateral plate, and subsequently that would never suffice, it continued to migrate medially. The only reason to show this was that this you cannot come out like this. If this is the situation, you have to go in and fix your implant, otherwise it would continue to migrate proximally. This is after a few weeks. So this is the pre-op. This is the pre-op. They did this. I'm sorry for the ABC, but when the patient came for follow-up, she was very painful. So they did a CT and found a fracture, and then they revised with a cup with some screws, so that would traverse the fracture and fix the fracture, and then she was pain-free. This is another example of multiple fractures in the dome, so they had to revise to a cup cage construct. Another example of primary hip being done here. The surgeon, this is again from the book, broke both columns and the cup migrated up. They revised it with a plate and a cup cage, dual mobility, sorry, and then it dislocated with dual mobility and the cup cage, and then they revised it with a constrained cup. If you can see, constrained cup also dislocated. So again, they revised it with a dual mobility. So that, I think, is the correct sequence. So this goes to show that the level of expertise required is very high, especially if you make this kind of this thing happens during surgery, both columns fracturing and making it very unstable. So to end this simple algorithm, intraoperative acetabular fracture, either is it displaced or undisplaced, you have to decide that. If the component is stable or unstable, it is recognized post-operatively. If the component is stable, you allow partial weight bearing, it may heal. If the component is not stable, you'll need to go in, and simplest device is a multi-hole cup with multiple screws fixation. You may or may not require additional osteosynthesis if stability is not sufficient. Now, if It is required, recognized intraoperatively, you can immediately change to multi-hole cup. And if the displaced fracture is an unstable component with either posterior column or discontinuity, you have to use osteosynthesis plus multi-hole cup, which is combined hip procedure or a cup cage construct. So in conclusion, intraoperative fractures do happen, more happen on the femoral side, high index of suspicion to first be able to recognize them and should be able to treat them. Don't try to hide behind them, don't try to come out with skin traction and other things. We need to fix them right there and then, especially if they're on the established side, either side. Knowledge about salvage options should be there, and change of approach or positioning may be required. If you are supine on a hard hinge and you want to go posterior, you may have to change. Backup of trauma implants is essential. Thank you very much. Any questions?